Welcome back to another episode of Sports Medicine on Tap. My name is Brandon Align. I'm sitting at Neck of the Woods Brewing Company in Pitman, New Jersey with my good friend Dr. Frey and our quickly welcome back guest, Dr. Mark Harwood.
That was a quick turnaround, man.
Quick turnaround.
It's great to be back.
That might be a record for the show.
I love it.
2 shows later, he's right back on it.
But it's another perfect topic.
Yeah. Just a great topic. So before we go ahead and get anything, just to give a quick shout out to our followers. If you're out there, give us a follow on YouTube and Instagram. And a quick shout out to one of our sponsors, Virtual Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip to yard work back and laptop ribs. Guess what? They have a doc for that. Find the right specialist for you at virtua.org/ortho. So, gentlemen, how are we doing tonight?
All's well.
Oh, good.
You know what? I was thinking on the way here is like, it's a great night to be here, but it's unfortunate that I didn't have sunglasses on driving at like 5 o'clock. And I was like, oh, it's starting to get dark early.
I know.
It's about that time. We're changing, well, you're changing your flavors a little bit and going with the darker beers.
That's what happens. Gets a little chilly out. Let's switch it up. Yeah.
But yeah, it's that time of year now. Now we're kind of getting back into the full fall of everything.
It's a nice feeling. I really like it.
Oh, yeah, for sure.
Mets are still playing baseball. It's a wonderful thing.
It is a great thing when you got fall baseball to watch, absolutely.
Sorry. Part of our last week's show, I don't know if you were listening, was a little bit of a joke at how we're foes and we want to get through, because as a Phillies fan, we wanted to get to the episode quickly.
It was one of the fastest episodes we did. We were talking so fast just to turn around and get the rest of the game going. So tonight we're talking about something a little different. It's not exactly hot off the press like most of the things
we've had this brewing.
We had this brewing a little bit. We wanted the story to develop a little bit more, and it's kind of at a standstill right now. And we figured, bring Dr. Harwood back on and we could talk about some of this stuff. We're going to dive into the story of Tufts lacrosse and their outbreak, if you will, or the story that developed, if you will, of a large number of the lacrosse players going into the hospital with what's was labeled in a lot of the articles a rare muscle injury or rare muscle disorder. So right, and that's what what we were talking about pre-show, just how rare is rhabdomyolysis, or which is also known as rhabdo, which we'll probably refer to as multiple times throughout the show. What is it and what happened here?
So rhabdomyolysis is it is actually a rare condition. We hear about it and we treat it, but it's a rare condition. Basically what happens is the muscle gets injured, and when the muscle gets injured, it releases enzymes, it releases myoglobin into the bloodstream, and myoglobin, for lack of a better way to put it, just kind of gums up the kidneys. It just kind of the proteins just get stuck in the kidneys, damage the kidneys, and the kidneys get a little bit leaky. You start to leak blood, and you start to have reddish colored urine, and in severe cases, the kidneys can fail, requiring dialysis or a kidney transplant. It can be very, very serious.
So to dive into the story a little bit here is back on September 16th, there was about 50 Tufts lacrosse players who participated in a voluntary supervised 45-minute workout led by a Tufts alum who recently graduated from the Navy SEALs BUDS training.
Intense training.
Intense training, which is, BUDS is not no joke for anybody. If you ever want to get a good book, Can't Stop Me by David Goggins, he goes into a lot of detail about BUDS training because he went through it multiple times and all this stuff. So a lot of crazy details coming from him. That's why I appreciated the story of that's really interesting background. So they had this workout. A bunch of guys, 50 players went through it, and then about 12 of them got diagnosed with rhabdo, 9 of which were hospitalized for an extended period of time. And I think the latter end of that, they were in for about a week to 10 days following this episode.
3 of them were in there, right?
At least 3 of it was in it for a long period of time. So, and now there's an investigation going on with Tufts, and they're trying to figure all this stuff out. And Tufts lacrosse program, men's lacrosse, is the reigning Division III national champion from last year.
They just won a national title.
So they had really good news. Now they're in the limelight for the wrong things. It's just that's tough. But it's not something that's, now again, it was reported as rare. But like we were talking about for us in the world of sports medicine, you see this a little bit more because we are involved in, those times of the years when, it happens a lot when there's a kind of an off season or a lull in training, and then you do a quick spike, and there's a quick increase of training where it's usually preseason training camp for football. When kids come back, at least in the college world, coming back from winter break or even after spring break, when they take some time off, and then I used to have a coach who was like, oh, we got to sweat out the turkey after Thanksgiving, and that next practice was going to be pretty tough. You know what I mean? So a quick ramp up in activity and training could lead to this, and obviously with in theory, a pretty strenuous workout. Put a dozen of these kids in a little bad shape there.
What time of year was this? supervised,
Yeah, so I think it happened back on September 16th, which is like the
voluntary
beginning.
supervised. It was
so-
September. It was early
Yeah, so
September.
early September. So again, men's lacrosse is a spring sport, so they're talking their off season, very basic off season starts when school starts. So
Right.
school probably started for them around the beginning of September. So we're 2 weeks into school, and you have this workout, and you do probably a lot more than you're used to, and then it starts presenting like cramping and like heat exhaustion type things, and things start getting, circling the drain, if you will, and then it's an ER trip.
What would be some signs or symptoms that like maybe kids or the athletes are heading in this direction?
It's a good question. A lot of times this just happens out of the blue, and oftentimes it presents after a really vigorous workout
Right.
without a whole lot of symptoms during it.
Right.
Because the idea is that you're working out hard, and the muscle injury, it takes a little while for it to manifest.
Yeah.
So the one of the things that is often seen with rhabdo is that it's got a very strong relationship with heat exertion.
Yeah.
Right.
And exertional heat stroke, exertional heat illness.
Yeah.
And so people who are showing signs of exertional heat illness,
Yeah.
those are folks that you have to worry that perhaps they'll present in rhabdo hours or days later.
Yeah.
After their symptoms. So the signs that you would see would be cramping, nausea, vomiting,
Right.
lack of sweating. Usually with a heat illness, in the early stages you're sweating profusely, but after your core temperature rises to a certain degree where
Right.
that system is dysregulated,
Yeah.
you lose your ability to sweat.
Yeah.
So as you get further into it, all of a sudden the sweating stops.
Yeah.
Correct. And in late stages, people lose consciousness, and it at that point it's very, very serious.
Right. So people, it's not as obvious during the workout, but shortly thereafter you start seeing some of these signs and some of these symptoms. What would be some of, and you described a lot of like the heat illness symptoms. What would be some of the symptoms that you would see particularly related, or some of the complaints the athlete may have particularly related to this if they're going into rhabdomyolysis?
It would really be soreness, and intense soreness.
Right.
So there's soreness that people experience from a workout. There's delayed onset muscle soreness, or DOMS.
Reading my mind.
Yeah, which is oftentimes presents 24, 48 hours later, and that's
Right.
the soreness that people complain about. Soreness that I had a really tough workout, and boy, I'm really way more sore than I thought I would be.
Right.
It's that type of soreness, just with a rapid onset.
Right.
So that soreness typically doesn't develop from delayed onset muscle soreness. Delayed onset, so we're talking a day or two later.
Right.
But people get really, really sore from rhabdo, like when it's happening.
Right away.
When the muscles are damaged, that is an extraordinarily painful situation.
I feel like in this, it was a little bit surprising to me at first, but every now and again I'll see a patient in the office that's there for what it is essentially turns out being DOMS, delayed onset muscle soreness, and like I think it's in that category. Like kids, they can run like Energizer bunnies, right? Like they can do anything forever, and they never pay a price. And as they start to mature, all of a sudden one day, and it's not like day and night, but all of a sudden, like, why does everything hurt? And they're like, something's wrong. And it turns out, like, welcome to being a little bit older. Right?
Yeah.
Like you see this in like the high school kid who's never experienced it before.
Yeah.
But like you're saying, it's a few days after, not like as your workout's winding down or an hour later.
It just doesn't go away, right?
Yeah, that's the big key, is that when someone comes in to see you, unless you're covering an urgent care and they come in right away, rhabdo is not typically something that we think about in the office,
Right.
Because it usually takes a day or two to get into the office, and by that point you're talking about the time frame that delayed onset muscle soreness would set in.
Yeah.
So it should be in the differential, but I can't honestly say that I've diagnosed a rhabdo in the office.
No, I don't think that's the way
That's
you do it.
Yeah.
Yeah.
Yeah, usually it's just like it's a medical emergency, emergency room trip.
Yeah.
They do the blood test, and it's like the CK levels are out the wazoo.
Yeah.
That was the next question.
Yeah, so we can talk about the creatine kinase levels next. But yeah, then next thing you know, then they're diagnosed with rhabdo, and then depending how bad it is, it depends on how, like, some of these kids, in this case, were in and out in like a day or less, and some had to stay for a little while.
What are your thoughts on urine testing myoglobinuria versus some of the blood testing?
Yeah, I think that this is a clinical picture diagnosis that utilizes testing as an adjunct to make that diagnosis. So clearly elevated CK, clearly urinary myoglobin help make that diagnosis. The problem is like, what's the cutoff?
Right.
Mm-hmm.
Well said.
And someone who has sustained a workout, who is a little bit sore, is going to have an elevated creatine kinase.
True. Makes it harder to figure it out.
It makes it really hard to figure it out. And one of the things that when I was in fellowship, my fellowship director at the time was one of the team physicians for a professional football team. And they often did their basically preseason blood work at a time slot that was after a workout. So they were seeing
panic time.
Yeah, so they were seeing CK. CK normal is like less than 200, 250 or so.
Yeah.
But they were seeing CK levels in completely asymptomatic people who had just worked out of 800, 900, 1500.
Yeah.
And what do you do about that? And so it really the wrong clinical picture. This is not someone who is coming in for an evaluation of muscle pain.
Right. That person's fine.
That person's fine.
Right.
But someone who's got severe muscle pain, who has a CK elevation of 2,500, that might not be just simple working out. The higher the number, the more slam dunk the diagnosis is.
Yeah, for sure.
But not necessarily indicative of how severe the disease is.
Interesting.
That's fair.
Right.
Yeah.
So I've seen some people in with a CK level of 10,000, and they're being discharged from the hospital. Right. And it's because they started out at 25,000 and they're trending down, and all their kidney numbers look okay. They're well hydrated. They've got the right the right post discharge instructions, things to look out for. But their numbers are still wildly abnormal compared to the general population.
Yeah.
Yeah, it's funny, when I was making the draft of my little outline here, there are some like studies that were done on like professional football player or soccer players, and they had, some of them would have up to 2,000, their CK levels would be in the 2000s, and like they're perfectly fine.
Nothing.
Yeah.
And the purpose of the article was to like, we should try to have a better idea of what our standards are for athletes, because if you go by 260 or 250 is like the norm, these athletes are never under that, because they're always working out at a high level, and they have an episode. And I've had experience with this of like, we had a really rough preseason. We had two kids with rhabdo, and one of them, was pretty significant, had to go on dialysis stuff for his kidney, and the other one, was released. But in that same breath of what you were saying, he had really high CK levels when we went in the hospital. And once they trended down low enough, they were like, okay, we feel like he's safe. But the numbers were way above 260, so it was like a big thing. And at the time, I was working with a new team physician, so we were trying to figure this out together. Our team physician, but the director that was above her was very like, no, athletes can have it in the 4,000s. Like, that's not a concern to me. So it was like, it felt kind of aggressive of like, oh, we can get them to return to play a little bit. Whereas like my initial thought was like, oh, we got to get these levels all the way down to 260 before we do anything. It's like, it's a little different for someone who's working out regularly, and it's like it's a kind of a normal thing.
Yeah, it's interesting. I love those studies. Those study designs are basically, you have a population of athletes that have blood, and we are going to draw that blood and see what those numbers look like in athletes. And they're always really interesting. Like, they're always really, because the normal values that you see in the general population aren't necessarily the normal values that you see in an athletic population. So I think that there is value to those types of studies.
Are you paying attention to the urine in this particular situation?
Certainly.
Color,
certainly. In a lot of these folks, they'll present because their urine is tea colored,
right?
Or their urine.
It's a big thing.
Their urine looks like
dark.
like Coca-Cola.
Yeah, Coca-Cola pee is not good.
Yeah, and so our patients will say, it was a tough workout. No wonder I'm sore.
Right.
And then they pee and it looks like Coca-Cola, and they're like, well, that's not normal.
That's
Right.
not normal, right?
And then they bring that to our attention. That's typically the way it happens. I don't know if that's how
Is
it
it- is
presented.
it
in
No,
your
yeah,
books.
it was something along those lines, and in those cases of like, we're gonna do a blood test regularly to track it, but then we also did urine samples of like, hey, you got to supply a urine sample, and it's just like, it's always interesting too, because like in the college world, a lot of times, not all the time, it happens to the younger kids. You
Yeah.
know, the freshmen who are away from home for the first time. They don't really know what they're doing. They're trying
Right.
to figure themselves out, being an adult for the first time.
Right.
And it's like, no, you got to stay hydrated, do all this stuff, and you supply a urine sample that looks like Coca, like it's dark. It's like, this is dark apple juice, man. Like, this is not okay for athletics.
That's right.
And you're coming off of this. Like, I can't let you do any more if you're not even trying to take care of the back end of things. And like, so it was like, it was something that we put into account when we kind of developed like a rational return to play, because it's like, if we wait for these levels to go down, we're going to be waiting for weeks. It might
That's
not
right.
happen anytime soon.
That's right. The return to play, return to work. There's a lot of data that is not necessarily in the sports literature, but it's in the military data.
Yeah.
Right.
And part of that is that one of the main physicians at Uniformed Health Services, who was a former past president of our AMSSM, the American Medical Society for Sports Medicine, has a big interest in this particular problem.
Yeah.
And it's certainly one thing to return someone to football,
Right.
where you can't really swing a stick without hitting an ambulance cab or a hospital,
Right.
within driving distance of the,
Correct.
of the football field. It's another thing to have a warfighter who's had rhabdo, and now you're about to deploy them to Iraq in 120 degree heat.
Right.
Yeah, for sure.
And so there are things that we do from a sports medicine perspective, and then there are things that people do from a military perspective.
Yeah.
So there's stress testing. There's a heat lab in Maryland where they'll put warfighters through a heat stress test before they deploy them into a war zone, because it's much more difficult to manage that
Right.
in overseas than it is here.
You have muscle breakdown, right? And that releases a lot of these we'll just call them toxins, sort of like stuff that really beats up the kidneys, right? It also releases certain levels, it changes sort of the electrolytes. Plus, the kidneys take a beating. They have a hard time processing and maintaining balance electrolyte-wise. What are some of the other, because this is a serious issue. Like it can be a really big deal. What are some of the other potential issues that people can develop as a byproduct, like acute renal failure? If that's not enough, there's also
I think a lot of it really is mediated by the kidneys. And I once had an instructor in medical school that said to think that the purpose of the kidneys is to make urine is kind of like saying the purpose of Michelangelo sculpting David was to make marble chips. Right? So the kidneys have a tremendous job in terms of maintaining homeostasis, maintaining electrolyte levels.
Right.
And when those electrolyte levels get thrown off,
Right.
Cardiac arrhythmias can happen if your potassium level gets too high or too low.
Right.
If your sodium level gets too high or too low, you can develop brain swelling and cerebral edema. So a lot of the problems that happen from rhabdomyolysis, or I would say all the problems that happen, are really a problem of kidney dysfunction, and acute kidney dysfunction, and the kidneys just lose their ability to do what it is that they do.
Scary stuff.
Yeah, no, it's
seizures.
Yeah.
Arrhythmias, like real.
And like the
real-
loss of consciousness, the collapse. I mean, I think we've texted about it a little bit this year of like, this past preseason August, there's a lot of stories this year of kids, unfortunately
We're
passing
going to
away.
do a topic just on that.
Just on heat illness and things like that. And it's kind of, again, there's a close relationship with heat illness and rhabdo. Like it's like that season when that August primetime preseason, we're out there in the hot days of summer, in the middle of August, especially when it's up here, it's hot, humid, especially if you go down south where it's even way hotter and way more humid.
Right.
There's just higher chance of this happening. And you see it a lot then, but it's just scary that it could happen that quick.
Right.
And they could just plummet, and then you have a kid just collapse on the field just from, they were kind of okay. They were doing a hard workout, and all of a sudden they drop. And it's like, you got to worry about all these different things. It's not just, all right, let's get them to the
Really
hospital.
big deal.
Yeah.
Yeah.
It's not like, one of those situations where you fall, you break your bone. All right, let's stabilize and let's get you to the hospital. It's like there's a lot of things that can unfold and cascade out of control if you don't take care of it like kind of right away and get him to the hospitals.
We have a guy in our group who kind of manages a lot of the kind of sports medicine portion of the equation, and sent out a group text to we have our the sports medicine kind of group text,
right?
And without giving out too much information, pretty generically speaking, hey, there's someone who just got a hold of me and their child has, I guess elevated CK. They're concerned about rhabdo. How much water should they drink through the weekend? And it was what? No. How quickly can they get to the ER? Right?
Yeah.
This is the wrong approach. You need to hydrate. You need to. Yeah. Speaking of that, let's say someone doesn't need. And I kind of giving away the surprise ending, right? But someone doesn't need dialysis, and they haven't gone that far down the road. But what are your first steps, and what are the things that you're trying to do, and or the hospital's trying to do to get that person to protect their kidneys and get them back into reasonable shape?
Yeah. So ultimately the treatment is really hydration and wait and hope that the kidneys recover,
right?
And support people while their kidneys are recovering. And some people, their kidneys don't recover and require dialysis, long-term dialysis. Some require a kidney transplant.
Right.
But if, ultimately the idea is that a young, healthy person that previously had no problems whatsoever goes into rhabdo, has acute kidney failure, that they will recover. It just will take some time.
Yeah.
And then so the management strategy is typically managing all the other problems that happen as a result of kidney dysfunction. So watching their potassium, watching their sodium, watching all of the other things that can happen, and looking out and making sure that they don't, or making sure that if they do, that there's someone there to manage those things.
Can prehydrating help reduce the chances of this? Or is it just hard workout, it might happen?
I don't think it can hurt.
Yeah.
I don't
Well
think
said.
I don't think it can hurt. I'm not sure. I think if you're going to have a really hard workout that's going to cause that extensive muscle damage, diffusely that spills into the bloodstream that acutely, I don't think any amount of prehydration is going to help.
I think at least in this regard of this college setting of they doing these group workouts, it's sometimes more is not more, right? You don't have to ramp up so fast.
Right.
That's a thing, at least as an athletic trainer, you see all the time. It's second day of camp, it's coach's favorite X, Y, and Z test where they do all this stuff. And it's we've had it, I've seen it where these conditioning tests, if you will, are so strenuous, and we've had all these issues with I've heard stories of we had a conditioning test, and we've noticed over a few years, all the freshmen or all these certain people of whatever, freshmen, young guys, always had all these problems. So let's change it a little bit so that the people who haven't done this before have kind of a training regimen to kind of build up to
Prepare for it.
Right. And it's most of these things is just, this workout 2 weeks into school. I'm sure these kids just came off the summer.
Right.
They just won a national championship. I'm sure they celebrated, had a good time, put their sticks down literally, and just took some time off and enjoyed summer.
Sure.
They come back in the first 2 weeks of school. They're going to a military training. You're going to have this uptick in all this activity, and you're going to have all this muscle breakdown and stuff that they weren't ready for.
And I'm sure the guy that was running it, I'm sure there's nothing malicious, but he's so excited to show these guys what he's just been through and what he can do.
Right.
Let's see if you can do it.
Yeah.
And not even paying attention to whoa, what might happen on the other side.
There's some details that are, we don't have access to all the details. There's a case that's getting investigated, so a lot of stuff is kind of locked down. There's not much media release of it.
Sure.
The same, I don't know, all the articles you read have all the same press release comments from all the people.
It's exactly the same.
It's all the same. It's all the same delivery, just a matter of who wrote it up. It's kind of, that's about it, with some different information. But we were talking before, how rhabdo isn't it's not that rare in the world when you see this sports and training.
There are other injuries
but
too.
The rarity of it is we were talking about, it's a cluster of it when you get a large number of it so fast.
Right.
And it brings media attention. It gets national limelight, and it's happened before. So I have some other instances of this. I found an article just from January of 2023, Rockwall Heath High School in Texas. There was a dozen football players who were hospitalized after a workout where the coach is making them do the 400 push-ups without a water break or something crazy, and then but a dozen kids go to the hospital and end up with rhabdo. And it's just like,
Of course.
of course this will happen. And I think there was a big one back in 2011 with
Yeah,
Iowa
Iowa,
football.
yeah.
Had about 13 players hospitalized after an off-season training workout. And with this one, it got such attention that I think the Journal of Athletic Training actually wrote a story about, or like an article about it, and they kind of did like a case report of their return to play with all these athletes,
Yeah.
and kind of like a staged return. And they kind of like, they took a really long approach to get everyone back safely and all this stuff, reintroduce activity slowly.
Yeah.
And it's like, if you just did that kind of stuff from the get-go,
Yeah.
granted, you don't have to go that aggressive because obviously at this point they're way deteriorated as
It's
an athlete.
super slow then,
Right,
yeah,
you
yeah.
super slow it. But if you just took some time in the beginning, you would avoid a lot of this stuff.
So, and I don't know if there is a definitive right answer. What is sort of the reintroduction criteria or process, or how do someone has the, maybe it's not 13 kids, right? Like,
Yep.
but it's just one kid, right? Like, what sort of that process of getting them back? Are there blood tests along the way? Are there multiple follow-ups along the way? Like,
Yeah, I think most of us will follow serial blood work, but most of us, I think, would agree that we don't know what to do with the results.
right.
Meaning that one would love to see a serum CK level go from 10,000 to 8,000 to 2,000 to 50 and follow the progression as they're
Right.
getting back.
Yep.
And I can tell you that I've never seen that. Right? Not ever. Like, they go from 10,000 to 5,000, and then they're at 8,500, and then and you end up with this like sawtooth. And most of us will kind of use those numbers as a trend line. Like, as long as it's trending in the right direction.
Right.
And there are a couple outliers along the way. We'll accept those outliers and just follow the trend.
Yeah.
But it's really about making sure that they're not developing tea-colored urine again.
Right.
They're tolerating their return to play without any shortness of breath, difficulty breathing, chest pain, and it's really about following their symptoms in addition to their blood work,
Right.
and just supporting them and letting it be known that they've just been through a potentially life-threatening illness,
Right.
and they have my permission to take their time.
Don't rush on this one.
Yeah.
Don't rush. Like, you were just in the hospital. You were in the intensive care unit. Like, you had arrhythmias. Like, it's okay to spend another week or two to get back to playing football. Like, let's put things in perspective.
Correct.
So that, I think that is the big take home from my perspective, is kind of partnering with the athlete, making sure that they're not withholding information because they want to go out and play.
Right.
Like, ultimately, you're there to protect the school, of course, but you're there to really protect the athlete. Make sure that they're not doing something that is going to be detrimental to them over the long term.
Right, and I think that's, again, where this thing, it's like one of those things where this is kind of preventable if you take all the measures that, you need to. And in regard to, like, what you were saying, like the return to play, it's like you kind of go back until it has all these close relationships with other things. As long as they're not having all these other things happen, if they can get their workout, they're not cramping, they're not really sore the next day, they're not, their urine is not dark colored, they feel fine, and their numbers are kind of trending in like a somewhat like downward slope, or they kind of normalize, where it's like, well, who's to say that this is their normal?
Right.
Like, this person, okay, let's arbitrarily say this person went to the ER and their CK level was 10,000, and they get back and you're doing all this blood work all the time, and they're not getting below 1,000 ever. But they feel fine. They're doing everything fine. All their numbers are fine. That could just be their normal as an athlete, and that's just something you got to just kind of work through on an individual case basis, because I'm sure you could get somebody who goes, I think it's fun. Ironically, I've had someone on the other end of things, like early on in my career, that we had to wait. We just kept waiting. Like, okay, we got to do less. You got to do less. Nope, you're off for another week.
Slow down.
Until we got that number all the way down to below 200 or something. It's like, okay, now you can go back.
Might have waited too long.
Now it's just like we just wasted some time where he could have probably come back a little sooner, or whatever the case was.
I think it's really hard, because I think ultimately, my philosophy, which I learned from my fellowship director, is, I don't want to sit an athlete 1 minute longer than they have to sit.
Right.
But I don't want them to play 1 minute longer that puts them at risk.
Right.
Yeah.
And
it's
so
hard to find that line.
It's hard to find that line sometimes, and particularly with this, because ultimately, are we treating the kid, or are we treating a number?
Right.
And oftentimes, if you're just waiting for that number to go down, you're essentially treating the number.
Yeah.
Yeah.
You need to look at the whole picture.
Yeah.
Yeah, exactly.
I think one of the crazy things about this is that it's so benign in the way that it develops. It's so like in the norm for everything else that's happening with kids normally, with athletes normally during that process. And then without you even being able to see it, if you don't have your antenna up and if you're not paying attention, it crosses over very quickly into this life-threatening situation.
Yeah.
But it was like this normal stuff. Like, oh, we were just working out. We were just training. We were just getting ready.
You just had some cramps. And
Right,
you
right.
need to take a minute. And next thing you know, you're about
Yeah.
to pass out on me. Whoa,
yeah,
whoa,
and like
you know?
your pee is the
Yeah.
color of
Yeah.
soda, the cola. Like, and you're like, what just happened there? Why does how did it get so bad so quickly?
Yeah.
And so if you're not paying attention, like things can get really, really bad.
Yeah, and I would love to hear kind of how this all presented.
Right.
Because it's unlikely that at the conclusion of that workout that 12 kids got up and went to the emergency department.
Right.
No, I was
Exactly.
going to say the same thing. Credit to Tufts sort of training staff and whatnot for like being like, whoa, we got
Yeah.
an issue here.
Yeah, it's
And
it's
getting
almost
taking care of everybody.
Yeah, like I think the athletic training staff probably functioned like a mini epidemiology center,
Yeah.
right? Like they were probably receiving texts from multiple different.
Yeah.
You know, I'm way more sore than I thought I was.
Right.
Yeah.
You know, I'm way more sore than I thought I was.
They're probably
Athlete
going
3,
between
you know?
the athletes.
Yeah.
Yeah, and
Yeah,
they
yeah,
were
yeah.
probably going back and forth,
Yeah.
and then someone probably said, "Hey, I'm way more sore than I thought I was, and my pee looks like this," and sends
Yeah.
a picture of it.
Right.
And then the athletic training staff has got to really put their heads together and say, "Hey, there's a there. You know,
Right.
there's a cluster
Something's
here.
happening.
Something's
Cluster,
happening.
Cluster.
happening, right.
Perfect.
You
word.
know?
Yeah, when you get that, that's not, it's just not a good sign. And it's like, and then I think afterwards, all 50 of them got examined. They all got blood work and stuff done. And I'm pretty sure
Yeah, of course.
afterwards, and
Right, right.
they covered all their, bases just with that, just because you never know. Like, and I'm sure, like we said, there's nine of the 12 I think were hospitalized and like admitted to the hospital. Where like, who knows to say the other 3 who could register like their levels were, rhabdo numbers or like high CK. They're just generally kind of fine. They might have had some dark urine, and that's about it.
Got out
Everything-
quickly.
They got,
Yeah.
just kind of
and
recovered
out.
pretty good. In and out, right. And that's the crazy part of like, yes, there's some, things where like, certain athletes with certain pre-existing conditions or other things are more susceptible to this, or, you kind of get like an obese athlete who's like an offensive lineman or someone who's just a bigger person, a lot more mass moving around. They're in this heated situation and that happens to them.
Higher risk.
And, there was also a case of this summer, like we talked about once before, was at Bucknell. There was a sickle cell rhabdo case, which is another added entity on this. And unfortunately, in this case, back in July, a young gentleman named Calvin Dickey Jr. ended up passing away from a sickle cell and rhabdo case, kind of a sickle cell rhabdo case that's like an added addition of things.
Yeah.
And that's, again, something that's preventable in that, like, NCAA mandates that sickle cell testing is required for all athletes. So you know their sickle cell status going into stuff, so you know how to change their training levels to prevent this kind of stuff.
Once people enter the spiral, that downward spiral, sometimes you can't get out of the downward spiral. Like that. The goal is to try to prevent entering the downward spiral.
Right.
You can't always do it, right? Like stuff happens. But like once they're in, that's a whole different world, a whole different entity.
Yep, and it's a different threshold for everybody.
Right. Yeah. Well
Right.
said.
Like some people will enter that downward spiral at a CK of 8,000. Some people at 25,000. Everyone is just a little bit
Yeah.
different.
Yeah.
And I think you see it in different, you see it in all those times, like I mentioned before, like all those increased training episodes after long breaks or whatever. Or you just get, it's usually the young guys. Like you get this freshman coming out and is trying out for the football team or trying out for the track team or whatever, and they do a really hard workout that they've never done before.
Right.
Next day, they're like, oh my God, I can't move, I can't walk.
Yeah.
What just happened to me? And they're peeing dark cola. It's like, oh man, this isn't good. It's like, no one would expect it. No one, like, and it just happens just like that.
Yeah. Well, Paul George hyperextends his knee and that. No.
Yeah. No, let's not even start on it's not even we're not even past preseason. We already got a topic for
What
Sixers
the
injury.
heck, man? It didn't take long.
Didn't take long
Two
at all.
topics. Joel Embiid, knee not looking great.
Yeah, and Joel Embiid's knee's not looking good. I just saw on the background here, Kawhi Leonard's knee's also not looking good.
Oh, really?
He's out for the rest of the preseason with knee inflammation, which we've talked about before.
Right.
And then last night, to top it all off, Paul George hyperextended his knee, reported just a bone bruise.
Yeah.
It's like, okay, it's a great way to start the Sixer season, where the next guy that's supposed to be the next guy up, and our next superstar that's coming to Philly, already injured.
They really put it in. They finally got a nice, nice additional piece of the puzzle, and the wheels are coming off already.
We're off the rails at this rate. Not a good look.
We're used to this, though.
Oh, yeah.
We're Philly fans.
It's just Philly fan. It's just a letdown of all letdown. It just keeps piling on. Philly's out of the playoffs.
Yeah. Sorry, man.
The Eagles are doing okay, but they're always in some kind of controversial media site.
Man?
We got our coach yelling at fans after the wins,
Come on,
all this
man.
stuff. It just never ends.
Yeah.
We've had a rough couple
You
years.
can't get lulled into that one. Come on.
No.
Anything else to talk about Rhabdo? I don't know if you have any other notes over there on things you talked about.
I think there been a couple of topics that we've talked about sort of through the years. It's crazy to say that, but through the years.
Yeah, for sure.
Where the big part of the equation is high alert. Just have your antenna up. Be aware of it, right? Like don't have your head in the sand. That's how you miss it. You don't want it to see you without you seeing it.
Yeah.
And as long as you got your antenna up, sometimes you can prevent the
and I think
problem.
with that too is just as an athletic training standpoint too, you're going to be monitoring these kids for a little bit before you pull the ripcord and call it EMS. But if they're circling that drain, go to sleep comfortably that night. Just call. There's no reason okay,
Well said.
you know what I mean? Sure, at the worst case scenario, you might have wasted this kid's time for a couple hours going to the ER, get some blood work done, and he comes out fine, no issues.
Yeah.
Best case scenario, you just saved this kid's life.
Yeah.
And I kind of had that situation where we sent 2 kids in the same day to the ER. One was in the hospital for a long period of time with dialysis, the kidney failure, the whole thing. One came out in a couple days and was kind of fine.
Yeah.
And the other
Why'd
kid
you
was,
waste my time?
Yeah, right.
Yeah.
And the one kid was like, "You saved my life."
Yeah.
And the other kid was like, "Can I just play football now?" It's just the complexity of this is just
But if in doubt,
when in doubt,
go the safe one. With this one.
especially later on in my career of now where I'm at. So, but what I'm going to do whatever's going to make me sleep better at night, because I'm not going to go to sleep worrying about this. And it's I should have done this, should have done that. Look now, making sure everything's okay, spending a couple hours in the hospital isn't that bad versus the alternative. You go home to your dorm room or wherever by yourself and something catastrophic happens, there's no one there to save you.
Right.
But I also think, what I think is also interesting is I remember when the NCAA came out and said that we had to do sickle cell trait testing on all of our athletes.
Yeah.
And I remember being a staunch opponent of that.
Really?
Yeah, because my thought process was, what are we going to do differently, right? So we should be preventing heat illness in everybody, right? We should have an emergency action plan, an EAP present.
Right.
We should have the cooling tubs. We should have all of this stuff for the rest of the population. What makes sickle cell trait unique in how we prepare for the season.
Right.
And I think that, Steve, you said it the best. It gives you yet another alert
Right.
for someone.
The antenna's up.
The antenna's up. The antenna's up for everybody.
Yeah.
We've got this EAP in place for if anybody goes down, but we're going to pay particular attention to people who are at higher risk for it.
Right. Yeah.
And so I've really come around. I've really come around. At the college, I used to be, getting 600 athletes and documenting their sickle cell trait in a big giant spreadsheet. What a pain in the neck.
Oh, yeah.
But you find those 2 or 3 every year.
Yeah.
And you pay a little closer attention to them. And I don't think there's anything wrong with that.
And especially if you're going to Denver to play.
Yes.
And that that's the big thing too is when I in the first few years of my career I worked at HBCUs, historically black college universities, and in that population you do have higher rates and more chances of this happening in the athlete population. So now I get maybe 1 or 2 a year, if that. Before I was getting 4 every year, and it was an incoming class of freshmen. You would get a couple. It wasn't and you had to adjust. And when I was at Morgan State, we went to Air Force in Colorado, and I called the guy and I asked him, I was like, "What do you guys What do you guys do for sickle cell?" He was like, honestly, a lot of people who come here don't let their sickle cell trait kids play, and there isn't much you can do about the altitude. Just people treat it like go in, get out, and you go about your business. And you just hope for the best and see whatever the case was. So that's what we did. We sat the kids who had it, and we're like, look, I'm sorry, you're just at a higher risk for something happening.
Yeah.
And just to avoid it, we're just going to have to play it safe.
One of the few reasons where like, yeah, that makes sense. You
Yes.
just,
Yeah.
you know, how important is
Right.
this one game?
And then it helps too, like, you know, in the preseason standpoint of things, like it is a pain in the butt to get all these sickle cell tests in. And
Yeah.
it's like, you know, it's like you feel like you're on a broken record. Well, you can call the hospital you were born at. You can call the state you were born at. They might have state records of your blood test when you were a kid. And we're getting all these old, you know, from 20 some years ago, these whatever blood tests from these newborn records, and you're trying to decipher which is the blood, you know, which is this, which is that. So it's one of those things that you dread all summer as an athletic trainer, collecting all these, right?
Yeah.
I mean, how many wrong blood tests
Oh my
do
God.
you get per
I
year?
get, you know,
Like-
basic blood panels all the time. Like, this is just your white blood count. Like, I got nothing on this. This is
Right.
nothing of importance. Like, I need something else. I need this test. I need that. And you just get them all, and it's like, okay. But then when you identify the few, you make a plan like we mentioned. And it's like, for us, it's always like, I let all the coaches know this is this person. If this person is ever in a workout or anything where we're not around and he's experiencing these symptoms, it's not just, oh, the kid's cramping. No, it's activating EMS, and we're getting this kid shipped out to make sure we're not missing nothing. This kid doesn't have to be catastrophic happens.
And I would even go so far as to say, like, every now and again, a reminder for a coach isn't the worst thing in the world, right?
Yeah.
Like, because they're there, and maybe you're on a different field or
Right.
across the field or God knows what. Yeah.
Yeah. It's just one of those things where it's like, like you said, it's like, it's a hassle.
Yeah.
It's a pain in the butt. But having that little bit of information and to make that decision, that red flag makes your decision a little faster, it makes a big difference.
Yeah.
All right, let's wind it down with some
Absolutely.
virtual action.
Absolutely. Before we go ahead and close out our tab here, we're going to give a quick shout out to our sponsors, Virtual Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip. They have a doc for that. Yard work back and laptop wrist. They also have a doc for that too. Virtual Orthopedics and Spine has over 120 providers, over 20 PT rehab facilities, and more than 25 surgical centers all across South Jersey. So find the right specialist for you at virtual.org/ortho. Also giving a shout out to Neck of the Woods Brewing Company and our guy Brian behind the bar serving us up the best beer in South Jersey.
Franco,
And-
I feel like we haven't seen him in like
Frank is
a year.
He's like the daggone Bigfoot at this, right? We haven't seen him in a while. And lastly, our guy Kyle over at Timber Road Production helping us get this all together, man. We appreciate you, and we'll see everyone next time. Thanks for listening.